All right, so now we're going to kick off our lectures on inflammation. So today and Monday are probably really two of the most important lectures for the whole semester. So let me repeat that. Today and Monday are probably two of the most important lectures for the entire semester. And the reason that is much of what we're going to study this semester has its roots in an inflammatory process. Many of these diseases that we will come in contact with, actually we won't come in contact with them, but we will talk about, we will experience in our minds, they're going to have an underlying inflammatory disease that is out of control. And so that's a common theme that we're going to deal with. And so if you can always kind of relate it back to that inflammatory burden, you'll find that these diseases are a lot easier to understand, because that's sort of the common denominator. So let's take the first one that we talked about, Barrett esophagus. Why do you think inflammation is a component of Barrett esophagus? What's causing the inflammation?
It's a response to a chemical.
It's a response to a chemical. Which chemical? Stomach acid, hydrochloric acid. Okay, so it's going to cause injury to the tissue. It's going to stimulate inflammation, and you're going to start recruiting inflammatory cells. Make sense? Those inflammatory cells that come into the area, they're going to do something. They're going to take residence, they're going to release growth factors and cytokines, they're going to cause tissue remodeling to happen. So today we're going to start to look at the aspects in the early phases of inflammation, what we call acute inflammation. Okay? From a timeline standpoint, acute just means temporally, it's the stuff that happens in the short term. Days, weeks to months. Chronic inflammation is defined temporally by being elevated for months to years. So we're days, weeks to months for acute, and we're months to years for chronic. Make sense? A lot of the stuff that we're talking about with acute inflammation exists with chronic. Really the only difference is acute comes up and then it subsides. Whereas chronic goes up, it stays elevated, it never dissipates. And that's where we get problems like with Barrett esophagus. If you've got GERD, gastroesophageal reflux disease, you have an occasional GERD episode or heartburn episode, maybe not a big deal. But if it's every day for 10, 20, 30 years, now you're in a chronic state. You understand? Okay. So, survival of organisms. I'm going to start here because inflammation is critical to our survival. Survival of organisms, it requires that we're able to eliminate foreign invaders and threats, like pathogens, infectious agents that are going to damage our tissue. And inflammation is one of our answers as a protective mechanism. It's considered to be named part of our innate immunity. That means that we're born with it. And in each one of us, it happens exactly the same way. There's nothing unique about inflammation. That's why if you take an anti-inflammatory pill, right, like an ibuprofen, an NSAID, an Advil, right? If you take an aspirin, an anti-inflammatory pill, it pretty much works the same in all of us because it's targeting inflammatory processes that we all share. In fact, all mammals have an inflammatory process. And it goes beyond that. All vertebrates have an inflammatory process. And in fact, many of the invertebrates have inflammation as a core innate process to the immune system. So the first line of defense as our innate immunity, these are non-specific. So inflammation is considered part of this innate immune system. Like we've got non-specific barriers, like the skin, we've got mucous membranes, we have hair, okay? We have mechanical responses that take place, meaning you can, close your eyelids, for example, and keep that external mucous membrane not exposed. And there's a reflex that happens when you get into that response where you'll blink a lot to try to minimize the amount of time that mechanical barrier is exposed. And then biochemical, like where inflammation would fall. And then you can see that we've got the left side of the slide where we've got all these other things that are going to be happening over on the adaptive side. So the innate immunity, where there's barriers, phagocytic cells, complement, all of those things are part of the innate immunity as our first line of defense. Now, once we get past that first line of defense, we have to get a little bit more detailed. Okay, so as the innate immune system, first line of defense of those barriers, mechanical and biochemical, like saliva and mucous membranes. And then as part of that innate immune system, inflammation is more detailed. And that's where we're going to spend most of our time today. And we're going to look at this slide in great detail today in a number of different ways. And I want to just first describe it right here, where this is actually a blood vessel. This is a slice, a longitudinal slice through a blood vessel. So you can appreciate some of the things that are circulating within the bloodstream. We've got PMNs, polymorphonuclear leukocytes. We have lymphocytes, and we have monocytes, we have platelets, and we have, of course, plasma proteins. All of these cells have the ability to be recruited out of the bloodstream. And when they get recruited out of the bloodstream, they can have activity as part of our innate immune system. Okay? So we'll come back to this type of slide here in a minute. But our third line of defense is the specific immune system. And the specific immune system we'll actually get to in week 7. So that's like the first week of October. And this is also referred to as the adaptive immune system that has 2 branches. And so we'll look at B and T lymphocytes in the early part of October. Okay? So that's how we protect ourselves. We've got barriers, we have mucous membranes, we have mechanical things that close, and then we get more detailed in our innate immune system in our second line of defense, which is inflammation. We're going to spend most of our time there. And then later on in a couple of weeks, we're going to talk about the specific immune system, okay, the adaptive immune system, the third line of defense. Questions about the overview, how this is all set up? All right, let's look at inflammation and what's happening, what's going on. So there are some local changes that take place. We've got some characteristics that happen at the local tissue. And all of you probably have experienced this. Not probably, most likely have. You have an injury, you've got dolor, which is pain, you've got redness or rubor, you have heat that's coming off of that wound site, it's hot to touch. If you sprain an ankle, you can feel it, it starts swelling and it's warm. We also see the swelling that takes place, or the tumor. And all of these are as a result of blood flow changes into the tissue. So all of this can be explained by the body's response to increasing perfusion into that tissue bed for specific reasons. We're going to see that here in a minute. So blood flow increases into the tissue and it becomes more flush or redder. Okay, so it's swollen because now you have fluid in that tissue. The vasculature that increases blood flow into that area becomes leaky. It allows things to come out of the bloodstream. Because of that cross-sectional picture that I just showed you a few slides ago, you eventually want, in an inflammatory response, you want these elements to leak out of the bloodstream. And so you make the vasculature leaky in order to accommodate that. And naturally, that's where the heat and the swelling come from. Okay, so let's talk about acute inflammation and what's happening at the level of the vasculature. What are we talking about here? Well, there's a rapid response to injury, and that rapid response has 2 main components. There are things that happen at the vascular level, or the blood vessels, and and there are things that are happening at the cellular level. And so you can see these two pictures. The top picture is normal microvasculature. So you've got the arteriole on the left, you've got a capillary network in the middle, and then the venule on the right. So blood is flowing from left to right. As the blood flows into the capillary bed, this is where a lot of the gas exchange takes place in the tissue. And so under this schematic diagram, you can see that under normal physiologic conditions, you have this picture that's taking place. If you have an inflamed situation, you're going to actually vasodilate. That's the terminology, vasodilate. V-A-S-O-D-I-L-A-T-E. So vasodilate means that you enlarge the diameter of the vessel, and the inflow tract vasodilates, and so does the capillary network, and so does the outflow tract, or the venule side. And by vasodilating, the inner lining of the lumen of the blood vessel, if this is a picture of a blood vessel, you've got, let's do it differently, let's do it like this. So the inner lining of a blood vessel has single cells called endothelial cells that line it, okay? And these things have these kind of tight junctions in between them, right here. You guys see that? Well, if we go to a vasodilated state, you actually enlarge the size of the vessel and you increase the distance between the endothelial cells. And as you increase the distance between the endothelial cells, you actually see these places where you can get transmural migration of components that were inside of the vessel. So you can actually get things squeezing out of the vessel and exiting. You also can get leakage of fluid. Okay, so we're going to talk about transudates and exudates here in a second. Does this make sense? This concept makes sense? So this vasodilation response is actually really important because you want to get these critical cells out to the tissue to help repair the damage or the trauma that's happening outside of the vessel wall. So vascular contributions in vasodilation, this leads to a relative stasis of blood, meaning the blood flow into that area is a little slower. If it's flowing a little slower and you get these openings, you get a greater opportunity for cells to have a chance to leave because the blood's not flowing too fast, right? So imagine like a river. Somebody falls into a river and it's flowing slowly, it's easier to find the bank and crawl out. If the river is flowing really fast, and you've seen some of these flash flood videos lately, it's harder for somebody who falls into the river to exit the river bank, right? Because the flow is so great. So it vasodilates and the flow slows down. You guys have seen this growing up as a kid. You turn the garden hose on, right? And you have a flow that's coming out of the garden hose and you want to spray your sibling, but you can't reach him. So you vasoconstrict the hose by doing what? You put your thumb over the end, right? Now flow increases. You take your thumb off, you have a larger diameter, and flow decreases. Make sense? All right, so you increase the permeability. We just talked about that. Allows for an increase in oncotic pressure in the extracellular fluid. Oncotic pressure is determined by cellular concentration. So more componentry outside, more cells and solutes outside of the bloodstream, water is going to follow solutes and more fluid will leave the blood vessel because of a higher oncotic pressure in the tissue. The cells pull apart just like I've drawn right here. And then you have the opportunity for both transudates and exudates. Okay, who wants to describe transudate versus exudate? What's a transudate?
Fluid only, exiting.
Perfect.
Whatever.
Period. Yeah, stop there. Nailed it. Fluid only. And what's an exudate?
Fluid and protein.
Fluid and protein. I'm glad one person read the chapter also. Fluid and protein. Everyone else is just shy. Okay? So fluid only is a transudate. And you can see this middle picture is illustrating transudates. So if you've got this scenario with a transected blood vessel for visualization, these are the endothelial cells that they've drawn. I didn't put any nuclei in mine. Let's make my drawing a little bit more accurate, right? So we'll put some nuclei here. This is on video, so we got to do it all accurate. Okay? So, same. These are the endothelial cells. My drawing is end on. You guys got that? You're looking down the tube versus this one's actually filleted longitudinally. You guys with me? So here you're seeing the gap between the cells right here, and you've got fluid leaking out. This fluid leaking out is because you've got an increase in hydrostatic pressure. What that means is the pressure inside of the tube is greater than the pressure outside of the tube because of the heart, even on the venule side, right? So pressure on the beating side of the heart, or when the heart cycles, right, the pressure is at about what? Millimeters of mercury under normal conditions. What's that? Yeah, so about 120, right, millimeters of mercury. And then under relaxation, it's still pressurized, and it's the lower number. It's the 80. It's the diastolic pressure. So this is definitely pressurized, and so that's why you got this hydrostatic pressure pushing the fluid out. Well, when that gap increases to a greater extent, and you get greater vasodilation, and you move those endothelial cells further apart, you make it large enough where you can get certain proteins leaking out. And those proteins leaking out with the fluid, it's going to encourage even more fluid to leave because of the increase in oncotic pressure. When you've got proteins extracellularly, they create an osmotic pole, meaning that water likes to follow solutes. And so when you've got a lot of protein outside of the blood vessel, water is going to leave the blood vessel. Okay? Let me just say this right now. We'll come back to it later in the semester. This is one of the roles of albumin. You guys have heard of albumin? So albumin is a very large protein, and it's made by the liver. The liver makes a lot of the proteins in your body. And so albumin is so large that it never really ever leaves. Doesn't matter how big the blood vessels dilate or how large of a gap you have in between these endothelial cells. It's too big of a molecule for it to exit, and that's important. Why? What is one of the biggest roles of albumin staying inside the bloodstream? It encourages the reabsorption of fluid on the venule side so that you don't have swelling that takes place in tissues. So albumin intravascularly is what reabsorbs, helps to attract that water to come back in because it has an oncotic pressure where it's pulling the fluid back in. That's how venules bring blood back to the heart. Is they all, it's like a sponge. They're sucking up tissue fluid because of all the albumin that's left over inside. Okay? I wanted to say that because I was pretty far along in graduate school until I really put that together, like the role of albumin. Like I always just assumed that, yeah, there's some magic that happens on the venule side and fluid goes back into the veins. That's how it goes back into the veins. That's pretty simple, that I don't know, maybe my teachers never took the time to say that. Yeah?
So what would our bodies do with an excess of albumin?
With an excess of albumin, you'll break it down and recycle it.
Okay.
Yeah. You'll excrete it. And then we'll talk about cases later in the semester, like in liver failure. I mean, you can look it up now. In liver failure, albumin is not made. And so there's a lot of extracellular fluid that hangs around in liver failure patients. And they actually get like this monster distended belly because of it. So we'll talk about it later. We're kind of getting... One of the big reasons I do slides is because then it keeps me from like getting way off track. Because I could easily just talk about starvation and cirrhotic livers. No, I'm serious. I mean, so that's where you see this Korsakoff syndrome, the starving kids. So I saw this go there. You know, like I remember as a kid, like, you know, they show these pictures of these starving kids in Africa. And they always were like fat. I'm like, I mean, they're thin, but then they had these fat old bellies. I'm like, they really should pick like a different example because that kid looks like he's eating a lot. Well, it's sad. This was my thought process as a child. Like, why are they showing these starving kids? Like, it was like I'm old enough where it was like this huge drought in Ethiopia, and they showed these Ethiopian kids and they had these huge distended bellies. The reason they have such distended bellies is because they're not making enough albumin, and so all the fluid is going and settling in their tummies, like in the abdominal cavity, peritoneal cavity. So that's a symptom of not having enough albumin in the bloodstream is all of the fluid stays out and never gets reabsorbed. And that's why those children that are starving have those pot bellies. It's called Korsakoff syndrome. Okay, well that's not on exam one. That's not supposed to be on exam one, I don't think. I think that's until, let's see, when do we talk about that? No, that's in the liver. That's all the way after that today. Don't worry about that yet. You can pause that one on the video. Okay, so what is causing these vascular changes? So all of a sudden, you're telling me it goes from this to this. Why? How does that work? Well, we get the release of numerous signaling molecules. We get molecules that cause vasodilation. For example, histamine. Histamine is released by mast cells. Mast cells are usually stimulated during trauma or injury, and they dump their contents. And histamine causes a massive vasodilation. Okay? So, classic example. If you have a massive dump of histamine because you have an allergic response, what happens to your eyes and your nose, right? Swelling, redness, they start watering. Okay, we're going to talk about that in allergy section with immunology, but that's the same histamine that we're talking about here. Histamine has a massive ability to cause vasodilation. And then that increases vascular permeability. That's what this is this vasodilation causing this to be more permeable where stuff leaves. And that's the drawing that you're seeing at the bottom is kind of my rendition here, but by some professional, okay? And there's other examples like cytokines such as TNF-alpha and interleukin-1, IL-1. These are from the kinase family. Or the big one known as vascular endothelial growth factor. So VEGF, vascular endothelial growth factor, is a highly vasodilatory molecule. And it's made and released at the site of injury. And macrophages, that we're going to talk about in a minute, they get recruited to that area, they release tons of VEGF, vascular endothelial growth factor. And that's what's causing this stimulus of inflammation to initiate. Do you guys all understand that this is so important right here? And I'm going to tell you why. We got to get this critical stuff out, and then they're going to do things. But this is a stepwise process, and we kind of have to walk through it methodically. So let's talk about that with vascular changes. Now let's talk about what happens at the level of the cell. I told you there's two steps. There's vascular changes and there's cellular changes. So these are all vascular stuff, and now we're going to talk about it at the cellular level. Well, back to this picture, just another textbook drawing. Again, cross-sectional view. So you're seeing down the middle of the vessel here. And here's our endothelium on both sides. And you got some, POW, like, Batman inflammatory symbol here. Some damage or trauma is happening inside of the tissue. And now, oh look, there's some cell that's squeezing across, just like I've drawn, being chemotactically attracted to that site of inflammation. So we've got a couple of steps here with cellular contributions. First, we've got to recruit the cells to here. We got to recruit the cells to the area. Then we need to activate them. And then they need to chemotax right to the location where they're going to be best utilized. Okay, so we've got a couple of molecules that we need to hear about. We've got selectins. Selectins are important in making that inner lining sticky or tacky. So as that cell is slowly rolling and sees the surface, the inner lining of the blood vessel, it partially attaches via selectins, and then it lets go. And as it attaches and lets go, and attaches and lets go, it starts this rolling process. Does that make sense? Because it sticks, but it doesn't stick and stay. It sticks and then it lets go because it's got a pressure head, it's got flow behind it, and it's like, right? And it's tumbling over, and that rolling process stimulates that cell to be activated. Once it becomes activated, it starts this expression of integrins. And integrins are not just tacky, they're actually going to tether. They're going to grab and hold the cell in place. And that's what gets it to bind and then lay down flat like this and allows it to what's called diapedese or transmigrate, okay, or extra vesiculate. So we'll look at this in a couple different ways. So we got recruitment, activation, and chemotaxis. All right, I've got a video here that I queued up.
Proteins embedded in the vesicle's membrane diffuse in the cell membrane. Essence of inflammation. Chemokines secreted by endothelial cells bind to the extracellular domains of G protein-coupled membrane receptors. This binding causes a conformational change in the cytosolic portion of the receptor and the consequent activation of the subunit of the G protein. The activation of the G protein subunit triggers a cascade of protein activation, which in turn leads to the activation and clustering of integrins inside lipid rafts. A dramatic conformational change occurs in the extracellular domain of the activated integrins. This now allows for their interaction with ICAM proteins displayed at the surface of the endothelial cells. These strong interactions immobilize the rolling leukocyte at the site of inflammation. Additional signaling events cause a profound reorganization of the cytoskeleton, resulting in the spreading of one edge of the leukocyte. The leading edge of the leukocyte inserts itself between endothelial cells, and the leukocyte migrates through the blood vessel wall into the inflamed tissue.
It's like an alien movie.
Rolling, activation, adhesion, and transendothelial migration are the 4 steps of a process called leukocyte extravasation.
Okay, so that's the only portion of this video that we're going to watch. It's like 7 minutes long. You can watch the whole thing. There's a link on the slide in lecture, the lecture slide right here. If you want to kind of watch the whole thing, okay? So let's talk about what he just said, kind of in a dull tone, right? I mean, all these videos, I don't know, they seem so non-exciting, don't they? But it's accurate. It's just maybe not quite as enthusiastic as what it could have been, but it tells the point. So I mean, 7 minutes, you know, with the lights down, you guys would be, you know, horizontal. All of you would be dangerous. So here we're going to talk about what was just mentioned in the video, right? So we've got margination, rolling and tethering, adhesion, transmigration or diapedesis, and then he didn't mention if a chemotaxis is once it's outside of the tissue, or sorry, once it's outside of the blood vessel, it chemotaxes to the area of injury. So I want you to know these steps, I want you to know them in order, okay? So let's look at the leukocyte, right? We've got a cell inside of the blood vessel. Now that the blood vessel is dilated, it's starting to express selectins on the endothelial cells. That makes that surface sticky. And the blood flow is slowed down a little bit, right? It's sort of like what we would refer to as a controlled coagulation. So in that stasis portion, when you dilate the blood vessel, you actually slow blood flow so much that on the edges, you slightly coagulate that blood in a controlled fashion. You make it thicker. So these cells are actually going to kind of slow down and almost naturally, through the viscosity of the blood, start their sort of motion to a rolling process. Then they see, so they marginate to the edge because of this controlled coagulation, because of the slow blood flow, because of the vasodilation that leads to this relative stasis of blood. They marginate. That just means they move to the edge. When they move to the edge, they see the selectins and they start their tethering and then braking, and you see these arrows? That starts them to roll. As they start to roll, they move into what's called this high affinity state. And this high affinity state is expressing the integrin molecule. So this integrin molecule you see where it's kind of like this is low affinity state, and this is high affinity state. And so this rolling process activates the white blood cell, and there's a conformational change at the surface of the white blood cell where it kind of goes from a low affinity state to a high affinity state, and now this integrin molecule sees its ligand, which is called ICAM1, and that's on the endothelial cell. And you can see this endothelial cell starts expressing more ICAM1s. These are the ligands that bind the integrin, and when all of these are bound, it is considered tethered, or sorry, adhered. It's considered adhered. And as it adheres, you can see it moves conformationally from a circular shape more to an oblong shape because it's kind of spreading out. It's kind of grabbing on in all these different places. And as it grabs on in all those different places is what it gives its ability to start using these PCAM molecules with CD31 and squeezing through or diapedicing, or what we call transmigrating through the vessel wall. Once it gets into the extracellular matrix, it's going to respond to a chemical gradient, and it's going to be chemotactically attracted to the site of injury. Make sense? Questions? Is that pretty clear, really? It was like, I've confused all of you, or it was so clear there are no questions? Wow, okay. I guess 10 years of teaching this is a good thing, huh? Okay. Well, if you have questions on this, SI is a great place to kind of digest through this process. If you can explain the different stages and details on this slide, then you have a pretty firm grasp and you're ready for that post-quiz and you're ready for the exam. Okay? All right. So what happens during activation? Activation of a white blood cell, for example, when this leukocyte, which is considered a monocyte inside the bloodstream, as soon as it diapedizes and leaves and enters the tissue, it turns into a macrophage. So, what we need to say is a circulating monocyte will turn into a tissue macrophage. You guys remember this cool tattoo? All right? So that's where you get tissue macrophages. You get them from circulating monocytes. And once it's out in the tissue, this macrophage is triggered to be in an activated state. And so I want to talk with you a little bit about what does it mean to be in an activated state. So we're looking at a tissue macrophage on this slide. This is the cell membrane. And inside of the tissue macrophage, we've got the opportunity for combative tactical execution. So these macrophages are like little soldiers. That's why they left the bloodstream. They left the bloodstream. Now they turn into a soldier out in the tissue, and this is what's happening inside of these tissue macrophages. So if they come in contact with bacteria or a foreign object, that's what that injury was. They come in contact with the bacteria, they bind this bacteria, right, to a phagocytic receptor, and then it's invaginated, or the membrane pinches in, and it pinches off and creates a vesicle around the microbe. And this is called phagocytosis. So macrophages, tissue macrophages are phagocytotic. They're able to, and phagocytosis means cell eating, right? So they're eating substances, molecules, large molecules. And then there's another term called chemocytosis, which is cell drinking, right, is what it literally translates, and that's small molecules. But this is phagocytosis because this is a large microbe that it's found. And the microbe is isolated, it's compartmentalized, and then it fuses with a lysosome that contains enzymes. And that lysosome that contains enzymes are digestive enzymes. And then these two fuse, and now you have a phagolysosome, right, which is the phagosome that contained the microbe plus the lysosome that contained the digestive enzymes, and now this microbe doesn't have a chance. Okay? So it's going to break down this microbe in a nice compartment, and once it does that, it can either excrete or get rid of, or it can recycle parts that it needed to, right? We talked about apoptosis in the last lecture. And apoptosis is a similar type of mechanism where now this will branch off and become an apoptotic body that can be phagocytosed or eaten by another cell. But this is a similar process, but with different, characters, because we're dealing with the microbe. Now, this picture right here is showing you at the molecular level what exactly is happening to kill that bacteria. And in the last lecture, we talked about the harmful activity of free radicals, reactive oxygen species. Do you remember that? So reactive oxygen species are very, very harmful, and we have a lot of combative mechanisms to neutralize them using antioxidants. But the other thing that you need to know is if you take the production of reactive oxygen species or free radicals and you compartmentalize them, you can actually have a very effective way to combat bacteria. And that's exactly what macrophages do. So they create reactive oxygen species at the level of their inner membrane. And this inner membrane on the mitochondria is taking arginine and creating nitric oxide, and then also is using phagocyte oxidase to take oxygen and making a free radical species inside of this controlled compartment, thus killing the bacteria with free radicals. But it's in this nice package. And so the bacteria dies inside of the cell, but inside of the package. Make sense? Question?
Why aren't the phospholipids in the phagolysosome oxidized by the reactive oxygen species?
So the question is, on the inner lining here, why are these cells rendered, not effective, right? So these inner lining membrane have a special glycocalyx, or a surface coating, if you will, that's a carbohydrate protein-rich layer that insulates it from the harmful effects of those free radicals. Yeah.
So after the free radicals do their job and kill the thing, then what do they do?
After the free radicals, then they're neutralized. That's a great question. Then they're neutralized so they don't cause any further harm. Okay? But this is how it's all supposed to work. Right? You get a cut, you see that it gets red, it's painful to touch, it's a little warm, it's swollen. A couple weeks later, swelling's coming down. A few more weeks later, the redness is gone, right? The cut's kind of healed, there might be a little bit of a scab, right? How many of you are like scab pickers? Come on, be honest. Who's a picker? Yeah, I got one kid that's a picker. I can't keep her off of a scab. Even if it's like on me. Stop, right? So that whole process is macrophages are there, and they're doing this activity and getting rid of that bacteria, because if you cut yourself on just about anything, there's going to be bacteria present. We live in a bacterial infested community. That's the environment that we live in. This is why we have these activities. Every now and then, that wound doesn't heal. And you've always picked up these news feeds, and you're like, flesh-eating bacteria, or so-and-so, and elderly patients really wrestle with this. I had a question right at the beginning before lecture started about pressure ulcers. Pressure ulcers are horrible in our elderly patients, right? Or diabetic foot ulcers, they're horrible. There is a huge bacterial microbiome that lives on our skin, okay? Meaning if whether you wash your skin or not, moments later, if you swabbed it and you cultured it, stuff would grow out. But we are equipped to deal with that for the most part. But in certain circumstances, like in our elderly population or in our sick population, like with diabetic foot ulcers or with elderly patients that are bedridden, that can't, if you're caring for elderly patients, your protocol is to probably come in, either do passive movement, right, or you're moving their arms and their limbs, or you're turning them, right, maybe on their side for a period of time, just to relieve the pressure on their back, okay, and obviously their bottom as well. That's their back and their bottom. It's also, there's a lot of moisture, a lot of sweat that happens there too, so it kind of is sort of a perfect storm. So they get these infected wounds that never heal. So at some point, this doesn't always work. So that's the less desirable effect. What happens if the bacteria wins out? What happens if the bacterial infection is so strong and so great that your ability to combat it can't keep up? And in that circumstance, we actually get what's called this respiratory burst. Okay, and that's what's on this slide. So it's called respiratory burst because this is a process of respiration because the oxygen is being used. So we have a respiratory molecule that's being utilized to create a free radical to go be our weapon against bacteria. But if this, remember, this is inside of a macrophage, right? A tissue macrophage. So if inside of that tissue macrophage, the bacteria is so prolific and strong that it takes over, then you've got a lot of compartments, to the questions that were here, a lot of compartments that house bacteria with free radicals that were supposed to kill the bacteria, but the bacteria wins, and then the macrophage bursts and lyse, and it dumps out all of these free radicals into this tissue. And what do you think that does to the tissue? It causes further problems, right? And that's when you've got a chronic inflammatory purulent wound. Purulent just means it's full of pus. Okay? Does that make sense? This is definitely less desirable effects like we're talking about here. So, this slide is to characterize these less desirable effects. What happens when the bacteria wins and the leukocytes get overtaken? Well, we've got reactive oxygen species that permeate out into the tissue, and then you get this fibrotic response in the tissue. You get scarring in the tissue and remodeling that never really fully heals. And so here's another picture, just a different representation. You've got the circulating monocyte adhering, flattening out, immigrating or diapedicing or transmigrating. Now you got 3 words for the same process. It's like, I know, this is scientists are horrible because everybody wants to name stuff. So immigrating, transmigrating, and diapedicing, depending upon what textbook or what piece of literature you're reading, they're all really referring to the same thing. So what am I going to say? I'm probably going to be using at least 2 of those 3 terms on the exam. I'll try to remember if there's multiple ways to reference it. But if you have a question on the exam like immigrating, so is that like a Trump term, or can you explain that one to me? So if you need clarification on the exam of what am I meaning by that, I will do my best to say, yeah, that's another word for transmigrating or diapedicing. Okay, does that make sense? So those are fair game questions to ask on the exam. Don't get stumped. Now, if the question is to define the term, then I'll just tell you, like, I can't answer that. Like, that's part, so that's part of the question. Or Ryan and I will be the 2 that'll answer those questions. You can raise your hand. Either one of them will come try to clarify the question. So now it becomes a tissue macrophage after it leaves, and you can see it goes from here. See how it has like mohawk? Now it's activated, so it's all calm and relaxed, and now it's got all it's all angry on the edges. So now it's activated, and in this activated state, it has the ability to release all of this list of chemical agents that trigger all of these activities. So we got toxic oxygen metabolites. What are those? Those are your ROSs and your nitric oxide. Those are toxic oxygen metabolites. Proteases, these are enzymes that digest things. Neutrophil chemotactic factors. So they're going to recruit neutrophils to come out of the bloodstream and come into the same tissue. Coagulation factors, other metabolites, all of these things lead to a fibrotic response in the tissue, or trauma or scarring. Fibrosis is another name for it right there. Okay, this is a scanning electron micrograph picture that showcases the main portion of the macrophage. Okay, this is a nice cool picture of it migrating. So it's migrating from lower right to upper left. So this is the pseudopod that's reaching out and it's kind of, army crawling across this substrate. And what it's doing is there's some chemical gradient up here that it's chemotactically attracted to. So the damaged tissue is going to be releasing like VEGF or histamine, and it's going to be not only vasodilating the blood vessel, but it's also a chemical gradient that these macrophages migrate towards. Okay? So you want them there because they can engulf the bacteria, they clean up the tissue, right? They can phagocytose damaged tissue. But again, we've just seen that if things get out of hand, then they themselves can be problematic. And so in the state of a chronic inflammatory response that we're going to get to really more on Monday, these macrophages stick around in that wound site for months to years. So months to years. Okay, so this is on the cover of a Biomaterials magazine. So that's where I was last week. So I was, last year I was the president of this Biomaterials Foundation. And so we had our annual meeting last week. And this was years ago, one of the publications on the front of our journal from Syracuse University that I borrowed for this particular lecture because it was actually quite nice. But I've been researching biomaterials for a long time, and on Monday you'll hear a little bit more about specific work that I've done in the past that's related to chronic inflammation. But this isn't my work. This is Jeremy Gilbert's. And I wanted to show this because what do you think, don't read it yet, but what do you think that's a picture of? What does it just look like? It looks like a target. I've had students think, it looks like, the surface of the moon. Okay, surface of the moon. So this is an example of a chronic implant. Okay, so this is a cobalt chromium metal total hip replacement. Cobalt chromium total hip is a solid metal surface. Okay, it's like titanium, but this is an explant, and it's a smooth surface. So the architecture that you see over here in the lower left, or in sort of the lower right, that's the surface architecture of cobalt chromium. You would imagine it to be very, very polished and smooth. So what the heck are these pits? What's that? It's the immune response, it's the innate immune response, but those are tissue macrophages that have been trying to digest away that cobalt chromium for the lifetime of the implant. So macrophages have chewed away and pitted this metal surface. They're trying to eat it using ROSs. Pretty crazy, huh? Yeah, it's insane. Okay, so what's a timeline look like for what's going on here? How would we characterize this thing? We've got days on the lower axis, right? This is just sort of a relative chart. We've got 1, 2, and 3 days. We can see we've got tissue swelling. That should make sense now. Why we get the tissue to swell? All right, we get the tissue to swell because in the early phases of inflammation, tell me what's happening. What's happening to the blood vessel? It's vasodilating. And now it's becoming leaky. We get transudates and exudates that are actually leaving, right? It's these pictures here. So that's that first peak of tissue edema. That means that we've got fluid into the tissue and swelling. And you all know that. You cut yourself, you damage the tissue, and it swells. You sprain your ankle, it gets twice as big. Oh, look how big it is, right? I got like cankles, right? Everyone's like, I sprained my ankle, right? So now the first cells that actually move in, believe it or not, we haven't even talked about them yet, but the first cells that move in out of the bloodstream are actually neutrophils. The neutrophils actually move in first. They're the first responders. They're the ones that show up right away. They're usually the most abundant white blood cell that's circulating. These are the PMNs, or the polymorphonuclear cells. and we call them our first responders, right? It's funny that, to me, it's not funny, haha, but just kind of interesting that we have adapted this terminology of first responders, right? We give, we get a lot of extra credit, especially on a day like today, to our fire and our police departments, being, 9/11, our first responders. But it's a very accurate scientific term, right? So our first responders in our community are actually technically named after neutrophils, because we have this was a terminology that's been way before we had the first responder terminology in our communities. So neutrophils are really those first responders. They're kind of like fire and police that show up right away. And then, similar process, but we characterize the monocyte macrophage recruitment process. The neutrophils happen to be recruited through a similar process. It's just a lot more simple. Okay, they squeeze through much easier. But the monocytes that circulate, they come on in about 48 hours. They peak after an injury. So they're our second responders. Okay, questions? So we are going to pause here, and on Monday we're going to start talking about the different types of inflammation, and then we're going to get into some of the mechanistic processes of inflammation, and we will then move right into chronic inflammation, and then we'll talk about biomaterials a little bit more on Monday with a peak related to our chronic inflammatory response. Okay? Kind of weird to say on a Wednesday, but have a nice weekend.